My name is Yoshi Schwartz, and I'm the director of the Transfusion Service Cell Therapy Service at Columbia University Medical Center in New York, part of the New York Presbyterian System. I'm doing this for many years now, and involve many organizations, include Standards for Cell Therapy, but I decided to do it today, since I know the audience is mixed, to really kind of concentrate on the towing of cell therapy product, no matter what the product is, and to kind of represent to you what the challenges are of a cell therapy or a hospital or a patient bed facility when they get, no matter what product are you want to get to the patient. So we'll get through that. So first of all, as a background, obviously cell therapy product, as you all know, are usually non-replaceable. Sometimes they are, most of the times they're not. So when we prepared cell therapy product for transplantation, and you'll have, excuse me, now it's not more transplantation, right? When you have, it's just sometimes just infusion, but as of habit, many of the slides has the word transplantation. So when we prepared product for either transplantation or infusion, the way we make it, the way we prepare it is really critical, and the preparation method really would like to or might affect the product quality, the viability of the cell numbers, the safety of the patient while we infuse the product, and if applicable for transplant, for example, the engraftment time. So again, just in the short, because we really want to talk about towing, but you can all go to towing because to understand the cryopreservation, and I'm not going to talk into details, but obviously stability of fresh cell therapy product is time sensitive. Thus, there are many situations we need cryopreservation in order to keep them viable. When we are doing autologous products, most of the time, if not all the time, they are being cryopreserved because that will allow us to collect multiple doses, collect multiple times, and we can store in advance for future transplant. As opposed to, by the way, to allogeneic product, which are usually, ideally infused fresh. In some situations, those are being cryopreserved as well. If you're donor in a different country, you have a limited donor availability, the patient is ready, you have to get the product and cryopreserved. Sometimes everything is planned for a fresh infusion. However, when the donor starts to mobilization, the patient gets sick, we get the cells, the process already started, we need to cryopreserve this allo product, and sometimes we need to cryopreserve leftovers for future infusions, such as donor T lymphocytes. So cryopreservation, sure, all of us, and we do it in the cell therapy lab, it's a slow clone and a control rate, and this is really not the focus of the talk today. And it's, obviously stored in liquid nitrogen in a very low temperature. But the important thing is for the towing is that we have one parameter, one material that we always use, and it's universally used for cryopreservation, is the DMSO, or dimethyl sulfoxide. We all call it DMSO, which is really a rapid penetrating molecule that increases the tolerance of cell to the osmotic stress of the cryopreservation. So a typical cryopreservation solution will always have some sort of a protein for the cells to chew on, such as donor plasma or human serum albumin, HSA for short, 5 or 10% of the DMSO, and polymers such as hydroxylated starch or dextran. This net cryopreservation solution is hypertonic. That's really important because now when we get to the towing, those cells in the cryopreservation solution will, because the cells now are hypertonic, will experience influx of water followed by efflux. That's what we want to get out this cryoprotective solution in order to reduce the difference in the chemical potential. This is a simple osmosis equation. What that means that the cells are very, there's a shift of the fluid, and cells are very sensitive to lysis upon expansion, upon swelling, and they obviously can lyse, and that's something we would like to prevent. So post-tow removal procedure are very critical to prevent cell losses. So then the goals of the towing, either the bedside or the lab, and we get to the difference in a second, are few. To minimize the loss of the cells, Those are non-replaceable. We want to minimize the cell loss. We want to maintain the cell viability. We want to prevent introduction, while we're doing all of that, introduction of microbial contamination. And we want to avoid recrystallization of any small intracellular ice formation. And also, at the end of the day, to reduce the DMSO concentration to prevent potentially damaging osmotic swelling that we just saw in the previous slide. When we tow, as I said before, we have no other solution for a cryopreservation. It's kind of a universal DMSO. But this DMSO is when we tow the product, is actually double-edged sword. We rely on it heavily for cryopreservation, but when we tow the cells, it can destabilize the phospholipid membrane at higher temperature, thus increase the membrane leakage and cell destruction. So, bottom line, when we tow cells, we have two options to reduce these potential damages. Either we would like to minimize the cell exposure time to DMSO, or we would like to reduce the DMSO concentration. Those are the two options that we have to minimize the cell damage for DMSO upon towing. Either we reduce the time the cells are exposed to DMSO while towing, or either we reduce the DMSO concentration. So this brings us to the clinical life in the lab or when we tow cell products. We have two options to get those goals. Either bedside tow or laboratory tow, and I'll talk on each one of them separately. I put them together because we can actually do both. We can swing for one situation to the other, but I wanted to, for this presentation, to show you each one of them separately. So let's talk about bedside tow, or more correct name is a direct tow, because it's not doesn't have to happen in the bedside. So this is an example we just had last week. It's hard to see, but on the left upper, we just had a cell therapy CAR T cell product. We just towed directly in the lab with no manipulations. We put in a dry water bath in the middle for 5 minutes, and voila, on the upper right, cells are with no manipulation being infused to the patient. But we all call it bedside tow and not direct, so that's really kind of what I'll go with. For the most part, I showed you in the slide, it can be in the lab, but for the most part, done adjacent to the bedside. A cell delivered frozen in the validated container, as we just heard, and again, from industry perspective, you can actually send directly to the patient bedside. Once it's ready to tow, the bag is removed from the shipper. We place it in a double envelope, a double overwrap, in order to, if there be any problem, will facilitate salvage of cells if there is any bag breakage, and reduce contamination in those cases. We put in a water bed, either 37 degrees, or now we use dry warming device. It's the same idea. And then when all those ice crystals are dissolved microscopically, the unit is removed, we infuse promptly. This is how we reduce the time. We infuse the product promptly, reducing the potential damage from DMSO. And if multiple units, we have to repeat this process again and again after making sure there is no adverse event from the previous unit. The advantage of bedside/direct tow, it's technically easy. You don't do any manipulation. It can be performed in some situations, small institution with no cell therapy lab, not such a unique tertiary care center like Columbia, can be performed even by nurses. Everything there is a good, there is a bad side to it. There are disadvantages to this bedside direct tow. We are reducing the time. We don't touch the concentration of the DMSO, so we are infusing a large volume of DMSO. The industry now does have a benchmark that you don't go over 1 cc of DMSO per kg of the recipient per day. So if that's your situation, if you're doing direct tow, you probably have to do multiple days of infusions. It needs to be quick because of this time frame. We don't touch DMSO. So as soon as we towed, we infused right away. And then lastly, it's outside lab control environment. So you cannot do any sampling of the product for the most part. You cannot do sampling, you cannot do product characterization. However, if you decide to do so, you can still take some samples, but again, those samples will be in the DMSO, so when you get them to the labs, you might not get a valid result or the result you are used to in your devices, because those are still sitting in DMSO. The other options we said, it's a lepto. The goal, reminder, is to reduce the DMSO volume. And when we reduce DMSO, we can actually reduce other elements such as cell BF cytokines that exist in cell therapy products. And with that, we decrease long-term effect and the potential infusion adverse reaction in the patient. So when we do washing procedure in the lab, when we tow and wash, by doing washing, reducing the DMSO, we're helping to destabilize the membrane and immediately reduce DMSO concentration. Not important technically, but the wash solution is as a mixture of dextran and human serum albumin. And it takes few dilution and centrifugation, and then you do removal of supernatant and resuspension of the cells. The point of the matter that it's a long procedure, probably take 2 hours to do all the dilution decentrifugation. That's really the take-home message from this long procedure. So the advantages of the lepto is done in a controlled environment. It's all done in the hood. It's all done by trained laboratory technologies, and it's allowing for sampling and prospective testing, such as viability or potency, that we always like to know what we're infusing. As we said a few times, much lower volume of DMSO is being infused. And lastly, there is a longer stability of the cells, allowing longer expiration time, which is a good when you need to get the cells to the patient bed. Longer expiration time is always a little better for us. There's always no good without bad. There are disadvantages. This washing procedure, dose centrifugation, dose dilution, every procedure to do to the cells, you lose cells. Most of the studies will show 10 to 30%, both on the total nuclear cells and the CD34. You can induce breakage. Again, you all know they are coming from the freezer. They're very sensitive bags. Now we put them into centrifugation, dilution. At any processing step, you have more chances to cell breakage. Then obviously we succumb to cell loss and microbial contamination. And lastly, you need highly trained and qualified laboratory staff to do that. So in this table, it's kind of summarized those two options, the different method for the cell therapy towing. You have a bedside tow, you have a lab tow. I probably will not need to go because I went through that, but this is one easy slide to show that the difference between the pros and the cons of both of these methods. What I would say, you can choose the scenario if you have the flexibility. So for example, bedside tow many times we'll do for adult patients that can tolerate high volume of DMSO, or in a smaller facilities, like Susan mentioned, that you do not have a cell therapy facility. The laptop, for example, we used in our facility that is also adults and pediatrics. We use it for the pediatric patients, because in that situation, we are definitely sure that we reduce the concentration of the DMSO. And lastly, what I want to show that at the end of the day, it's really depend on the patient population, the setting you are, and this is our tow request that exists in our facility. So the upper part is being filled by the transplant physician, or no matter the physician who is infusing the product, and you can see that this is what the product, this is almost a menu. It's apheresis product, it's HPC marrow, or nowadays there are many MNC apheresis products, like all the CAR-Ts and any other products. You can see that we ask them to choose no washing or washing, because they need to know the scenario of the patient and what's going on, what's better for the patient. And actually, they even lepto or bedside tow. And at the end of the day, they sign that, but also that in the bottom you can see the transfusion medicine, one of our physicians. So it's a mutual decision of what will be the best towing procedure that this patient will require for those specific cells we're having. So at the end of the day, it's kind of a dialogue. And in conclusion, what I wanted to say that towing of cell therapy product can be flexible and can be different from product to product and from patient to patient based on different specifications that determine the best approach for a product X or transplant center. It's worthwhile to perform kind of a benefit-risk analysis to the specific situation and variable that probably will be included will be the patient demographic, adults versus peds, availability of trained staff, cell therapy lab, yes or no, and the transplant setting or infusion setting when it's not transplant. Thank you for your attention.